Thank you, everyone. I really appreciate the opportunity today to really campaign to you to activate this study at your institution. As Roshni mentioned, this is really an opportunity for us as the surgeons to show that we can do a study in COG and have it be a success. I'm the surgical study vice chair. It wouldn't be right to start this talk without crediting John Doskey, who has really been working on this study for 10 plus years and really is owed a great deal of gratitude for his work on this. So a little bit of background. Metastatic osteosarcoma has a 15 to 35% long-term survival. And really, in order to achieve any long-term survival, complete surgical clearance is necessary. And we know from several different studies that manual palpation during thoracotomy does allow you to identify additional nodules that were not seen on preoperative imaging in up to 20 to 25% of cases. However, we don't know if that actually impacts long-term event-free or overall survival, finding these very small microscopic nodules that weren't seen on CT, okay? And in fact, in the recent PSORC study, where we reviewed 202 patients, we showed that there were comparable outcomes after thoracotomy and thoracoscopy for those patients who had a small number of nodules, 4 or fewer per side. So the aim of this randomized phase 3 study in COG is to determine if open surgical resection is superior to thoracoscopy for thoracic event-free survival or overall survival in patients who have what we're calling oligometastatic osteosarcoma, which means 4 or fewer nodules per side. There are a number of exploratory aims, and I don't want to get sort of bogged down in these exploratory aims, except to say that there are some other very important questions that are going to be answered in the study besides just the question of optimal surgical approach. So we're going to look at things like complications. We're going to look at patterns of recurrence. So if you have nodules just on one side, do those occurrences occur on that same side, or do they occur on other sides? We're going to get some good exploratory data about the use of localization techniques for thoracoscopy with the help of our IR colleagues. We're going to look at what it means when the plan changes at the time of surgery. We're going to correlate the imaging findings, the surgical findings, and the pathologic findings. And importantly, there will be very good prospective patient-reported outcomes comparing these two approaches. Here's the eligibility requirements. So these will be children and young adults, so up to age 50. As I mentioned before, the main criteria is that there needs to be 4 or fewer nodules per side. At least one of those has to be clearly metastatic osteosarcoma based on the imaging. And we'll talk in a minute about the central review that will help with that. But that means that at least one of the nodules has to be 3 millimeters, and none of the nodules can be huge. So none of the nodules can be 3 centimeters or larger. And they must be peripheral. They must be appropriate for a wedge resection and not something that would require a lobectomy because of the central location. They must have had successful local control at their primary site. They can't have any other metastatic disease outside of the lung. And this has to occur at one of 2 time points, either at initial diagnosis or as first relapse. And importantly, also, last point is that they can't have had prior surgery in the lungs for osteosarcoma. This study will employ rapid central review of the imaging, and this is going to create some of the time frame urgency that we're going to talk about in a second. So after enrollment, the images will be sent for central review to confirm eligibility. This central review is not going to tell you exactly what your surgical plan is going to be. It's not going to say exactly these nodules need to come out or anything about approach or localization. What it will say is it meets the criteria of 4 or fewer nodules that meet size criteria. And then all patients are going to have their chest CT within 28 days before the planned first surgery. So this is what the sort of roadmap looks like. And we're going to walk through this, and you're going to see that it is pretty tight, which is why it's going to take some rapid action on everybody's part to get patients onto this study. So after they're diagnosed with metastatic osteosarcoma, they'll get their preoperative chest CT. We want patients to get enrolled within 3 days after that chest CT, and we recognize that this is probably the hardest part of this. But after they get enrolled, there's a lot that still needs to happen in order to get them to successful surgery within a month. And so rapid discussion with your oncologist and enrollment is very important. After enrollment and randomization, the scans get sent off to IROC, and then they undergo central review. And our radiology colleagues are very committed to this study, and they're going to do that review within 3 days. After we get the confirmation of eligibility, then you have surgery preparation. Obviously, you already will know the randomized assignment, so if you have some different considerations about localization techniques, depending upon the randomized technique, you can start that preparation early. And then we want to get to the assigned surgery within 28 days of the scan. Now, if you do bilateral surgery in a staged fashion, it's just the first operation that needs to be done within 28 days, but we're doing the second operation within 14 days after that. I know there's some difference in practices with some people doing another cycle of chemotherapy before the staged contralateral procedure, but we're going to do them all in the same 2-week block. There will be some checklists that will be important for us to get the data that we need. If you do use IR for localization of your nodules, and you can use whatever localization technique you want. Some people use microcoils, some people use wires, some people use dyes, some people use technetium. You can use whatever approach you want, but we're going to ask, there will be a checklist that will be completed with the help of the interventional radiologist to make sure that we have the data on that. And then the surgeon, it'll be important to include all the data in your operative report that's needed for the CRAs to submit the surgical checklist. And so that's going to include your perception of how many nodules there were on the scans, and then how many nodules you identified in each of the lobes of the lung for resection. There will be some of these additional studies that will be part of this. As I mentioned, there will be patient-reported quality of life assessments that will occur at baseline, in the first couple days after surgery, at 1 to 2 weeks after surgery, and then 4 to 6 weeks post-op. This will be completed electronically through REDCap, and that'll all be handled through the CRAs to enroll patients on your COG studies. There will be some additional optional studies, and these optional studies are really what have the oncologists and the biologists excited about this study, is because we're going to get a whole very detailed annotated library of specimens that can be used to study this further, because we are still using the same MAP chemotherapy that we've been using since the 1980s on this, and so we do really need these annotated specimens. And this is really the important slide, is how can we, as the APSA community, make this study a success? So the first thing and the most important thing is to get the study activated at your institution. Every institution that's a member of the COG has a PI. That'll be one of your medical oncologists who's responsible for getting studies activated. And so talk to that person, talk to your solid tumor oncologist, and make sure that AOST2031 gets activated. Because you can't wait until you have your first patient to activate the study. You really need to have it done in advance. I would then strongly recommend that you identify a surgeon champion within your group that can keep an eye out for patients who would be eligible for this study and can help to make sure that all the timeline restraints are met. Please consider this study and speak with your oncology colleagues for any patient who might be eligible. Even if you don't know for sure the eligibility requirements, if you have the conversation with your solid tumor oncologist, they're very facile about going through the protocols and checking all the eligibility requirements. Please also spread the word to your adult thoracic surgery colleagues. As we mentioned, this study includes patients up to age 50, and they can be enrolled not just through COG, but through the other NCTN groups, so SWOG or Alliance or the other groups through NCTN. So please talk to them if they'd be interested in participating. And then work with your colleagues to enroll patients. We really appreciate your help with this. This is what the study looks like. This is the visual abstract that we sent out through the APSA listserv before, but I'm also happy to get to anybody if it'd be helpful to have as a resource. It summarizes the inclusion and exclusion criteria, the interventions, and the primary, secondary, and exploratory outcomes that we're studying. So with that, everybody on the study team is very, very available to answer any questions. Please do not hesitate to reach out to us if we can be of any assistance. And please bear in mind that we need to have the study activated at as many institutions as possible, and we need to be thinking about it very proactively so that we can get patients enrolled in the admittedly pretty tight timeline. So I am happy to answer any questions about the study. Thank you.
Thanks, Tim. That's very important. When there's a virtual question.
This is from Cynthia Reyes. Can thoracoscopic ultrasound be used for localization of nodules in the study?
Absolutely. Thank you. Yes, that can certainly be used intraoperatively if that's a technique that you're comfortable with. I would not encourage anybody who hasn't used it before to embark upon that as sort of a planned first mode of localization, but if it's something that you've used in your institution, please do so.
Dr. Schamberger?
Bob Schamberger, Boston. So Tim, I'd like to congratulate you and John for shepherding this protocol through the COG network and the CTEP to get it approved. It's taken a huge boatload of work. And I would like to encourage all of the surgeons to participate in this. Our participation is critical to the success of this study. And I would commend all of the surgeons who participated in the study that showed that expectant observation without chemotherapy for the small Wilms tumors was successful, that expectant observation for small neuroblastomas in the perinatal period didn't require surgery, and the recent study that looked at bilateral Wilms tumors. So only with our participation can this study be successful. I will tell you that the oncologists have been doubting Thomas's since it was first proposed, so I think we all need to prove that they're wrong. Thank you.
Thanks, Dr. Schamberger.